So let's reconvene. If everyone could come back to their seats. Um,
See these little words on the computer.
yes. So let's find you.
Oh, no matter what you do, you can't stop the thinking. Okay.
Dr. Vega, we are going to have you head over there, and Chris right here is going to put a mic on you.
Oh, okay.
Perfect, and I'll get you set up.
So if folks at the back of the room could come on up and take a seat, that would be wonderful. So just a note on the rest of the day. The extra time that I built into the schedule was in the form of a break, which we slotted in after our plan for Dr. Vega's keynote address. So what we're doing now is we're just going to pull that break out of the agenda. And after Dr. Vega speaks, we will continue in the format that we've been using so far with the panel discussion. So I'm hopeful that there are no serious objections to that. So I'm extremely pleased to introduce Dr. William Vega, who I think might win the award for the longest distance traveled to be here. Very generously came from California, and I said, well, what else are you doing while you're here? And he said, nothing. Such generosity. I mean, that is a big commitment, so I really appreciate that. On 2 days to come and be with us. So Dr. Vega is the Provost Professor and Director of the USC Edward R. Roybal Institute on Aging. I was interested to see that his original training was in sociology and criminology. Very interesting, and I think a helpful perspective today. Dr. Vega's in the top 0.05% of the most highly cited authors worldwide in the general social sciences. Incredibly impressive. He has numerous publications and grants in related areas. And I think extremely relevant for our conversation today, appointments in many schools: social work, preventive medicine, psychiatry, family medicine, and I know you do work in aging as well. So I just want to express my gratitude for you being here today. Thank you. I think this is going to be an exciting talk, so thank you.
Thank you very much.
Thank you. You're all set?
Okay, so I move this forward with this thing, I guess. Let's see. I've got to practice first here. Let's see if I can really do this. Yep,
Great.
it works. All right. Well, first I'm going to assure you that this is going to be such a refreshing presentation you won't need your break anymore, all right? Get you started on an upbeat there. I just wanted to say that I think this has been an incredible morning. that we've had such excellent presentations and such granular information in enough different directions. Fortunately, since we didn't really plan these in that tight a sense of being sure that we weren't overlapping too much in our content, the presentation I'm going to be doing is going to be somewhat on an off angle from what we've been doing so far, because I'll be more focused on actual public health, population health, as opposed to healthcare delivery. And I think that's an important distinction, because obviously we've heard already that we're good at describing problems, and maybe not solving them, but describing them. And the other thing is, I think it's very important, is it's harder for us to have such tight parameters on determinations of things, because we deal with very wide processes. And it becomes somewhat more diffuse to really understand what's going on. So in my presentation, I'm going to be concentrating, as I think well, let me start with this. I put this on only for one reason, because it's so emblematic of the times that we're in right now with all of its contradictions. This is a sanctuary of Haitians. This sanctuary of Haitians is in Tijuana, Mexico. Tijuana, Mexico is not the Paris of Mexico. And so they are not there for a vacation. They're trying to get across into San Diego and then into the United States. And this has been piling up, not just Haitians, other people from the Caribbean and also of African origin are piling up in Tijuana, and the government doesn't know what to do with them because there's nowhere to send them back to, and so it's very difficult to know how to handle this situation. And this isn't a border that has 500,000 people crossing on a yearly basis. So it's an extremely active border, and this is almost on a daily basis. A lot of that number moves back and forth because a lot of people work on one side and go back and forth to Mexico again. So it's just emblematic, I think, of the pressures that we're feeling all over the world from people trying to get to us and us not knowing quite how to handle all of this, this movement. Now, I represent the Roybal Institute on Aging. Ed Roybal, I don't know if you're aware of it, he was the first Latino ever elected to the Congress, and actually probably did more during his career to advance money for looking at issues that we would today call issues around equity research and disparities, probably than anybody else. Both for the NIH and for the CDC itself, and many public buildings are named after him all over the country. He started his career in the 1950s campaigning in the Mexican movie theaters, against the issue of TB, which was rampant in the Mexican community at that time. My mother had TB, and my aunt had TB as well. And at that time there were no cures. I mean, there was no therapies that were effective. They just put you in hospitals and you'd rested and you tried to regenerate, physically the best you could. So he was going around campaigning during the intermissions in the movies, and he was so effective at it as a sort of an early public health person, spontaneously doing this. He wasn't hired by anybody. He just went around and did this work. And as a consequence of that, he had enough visibility that he was urged by the people that lived in his area, which is East Los Angeles, to actually run for city council. And this is back in the mid-50s again. And he actually ran for city council, and he won. And the day he came into the city council quarters for the meeting, since he was the first Mexican to ever be on the city council, can believe it or not, in Los Angeles in the 1950s, the other city council people walked out. They did not. This is when LA was still redlined, and they just had the Pachuco riots and all this kind of stuff back in the late 40s. So there was an enormous issue there, and African Americans and Latinos were very redlined into their zones of the city, and there was a lot of prohibitions to buying in other areas of Los Angeles at that time. But despite all of that, and I say this only because he went through a period that's not dissimilar from what we're looking at right now, in the sense of all the blocks that were being put in front of him. His own family, his own children, were under a lot of stress from other people in the community, calling the house constantly, cussing out the family because they're a bunch of Mexicans that were presumptuous enough to be doing what they were doing and taking leadership. The children had to have safe houses on their way home from school to safeguard them from the police. So it takes courage to move communities forward, obviously, and I think that he was a vibrant example of exactly that. So I think today, in today's time, he'd be probably shocked. He died some time back, and he actually started the institute that I head when he retired from the Congress. But he would be shocked by the conditions that we're facing now in this country in terms of all that was fought for and won seemingly, and yet, we seem to be in this rapid state of going perhaps sideways, if not backwards. So I would start this presentation just at that point where we're in an earthquake, and it's really hard to see the horizon right now to say what we can do and what will be actionable, where the opportunities will be, where the blocks will be that we shouldn't move down anymore. And so I think at this point it is a little bit premature to be prognosticating. I have no crystal ball to be able to do that. I would like to spend my time evaluating 3 primary issues linked to health disparities to understand their individual and combined impact. And first, I'd like to look at the impact of income on health as a primary cause and its potential as a lever for improving population health. And I think it's somewhat odd, that we haven't talked about income. Because obviously, at the primary driver in this picture is inequality. Beyond racism and everything else, unequal income is pushing, so much of the disparities question and its resolution because of the simple issues of all these other barriers, and I'll get to that in just a moment, are affected by it. And then second, I'm going to look at the viability of community-based approaches and their potential as an alternative or complementary approach to improving population health. And I think that this has really come on the front burner now with the latest report from the National Academy of Medicine, which I'm going to talk about in the latter part of my presentation. And third, I want to talk about the critical role of promoting culture of health, because I think any place I've seen has been successful, and even with NIH projects that have been able to move into an area that they've identified and have actually moved to the point where their prevention efforts were successful, only did it after changing the culture of the institutions that they were operating with. And it took decades to do it. Decades. It wasn't a year or two. It wasn't the lifespan of one grant, and that they changed everything in 2 or 3 years. It took a long time to change people around, to share a common orientation to move in the same direction of the deterministic arrow, to all pull in the same direction and harmonize their activity. So I think that's something and I'm not using culture of health here strictly in the identification of that as something that's being pushed forward by the Robert Wood Johnson Foundation. I think that's an important effort, but I'm not speaking about it in those terms narrowly. I'm speaking of it broadly, of the need for really developing a strong commitment and orientation from stakeholders, and that involves public and private and other sectors as well. So from there, let's move on. Now, we know that the fundamentals of income, are well established. We've seen some of it up here already. Embedded early poverty is linked to poor longitudinal health outcomes because we know you age faster, you have more health problems throughout the life course, and you die sooner. Life course trajectories of income associations with health have different patterns conditioned by exposure sequences, and that in terms of when you're exposed to the poverty. When is it most important in your lifetime? And so we know the early is the worst in terms of having pernicious outcomes. And we know that it also varies, of course, by your gender role, and it varies by health behaviors and environmental context. Social stress effects on health are linked to social position through physiological responses and health behavior adaptation to prolonged exposure to concentrated poverty. And that concentrated poverty comes back again and again as being a very special case scenario, because concentrated poverty seems to put people in such low resource situations that there's just not much there, to bring together. And that's where we have the toughest times, it seems to me, in turning these types of issues around. And income distribution and area wealth, of course, we all know that. The zip code issue of zip code is going to say a great deal, about how healthy you will be and how soon you're going to die. Now, this is a very simple social epidemiologic model that I constructed just to make my presentation simpler to understand today, that I'm really looking at income as a primary driver and looking at the context in which it plays out as the places that you have the exposures to lifestyle creation, to pernicious behaviors, to threats to your life, to trauma, etc. And obviously this varies enormously, so the burden level varies according to where you grow up. And obviously the likelihood that you'll undertake unhealthy behaviors is also affected by stress coping processes and by availability of the food chain, etc. And ultimately this ends up at the end of your life course affecting your functional limitations and how soon they will begin to onset and begin to really create some disabilities for you in later life. And of course life expectancy. So if some of you are public health people, you're aware of the county rankings approach that's been taken by the people who do this kind of work and think about this from a public health perspective. And what they have done is they've taken these domains of areas affecting the production of health, and they include health behaviors, clinical care, social and economic factors, and physical environment. And they've actually assigned a weight of each of those to the total production of health, which is based on their critical review of the literature. It's been very influential. This model has been very, very influential, used by a lot of people. I think the critical thing here is, if you'll notice, the highest factor goes to social and economic factors. And of course, we got health behaviors here at 30%. That's certainly important. Clinical care at 20%, especially in early and late points in the life course. And up down here, physical environment. The critical thing from my perspective, though, is that social and economic factors are primary to the other three domains. They're really primary. They're really structuring those other three domains. And those other three domains are very much situated in communities that offer quite different levels at which those things will have an effect. So the whole interplay you see between income and environment, over the life course, I think is very, very clear. So here, I wanted to just show you, because this hasn't been shown so far. We've certainly talked about lower life expectancy, but nobody's spoken to the issue of how rapidly we're seeing the changes matching the changes in inequality in the United States that have taken place since 1980 to 2010. You can see here life expectancy of 50-year-olds that used to be only 5 years different from it in the United States. And these are quintiles in the population, bottom quintile, the top quintile. You can see that what's happened over that period of time is that there's been enormous life extension gains by men in the top quintile and the fourth quintile, which is 60% to 100% of income, and also here as well in the third quintile. But down here, very little life extension has been taking place during that time, and of course that's very much matches. So my question becomes, as we talk about these disparities and we sort of shoot with a rifle at a certain disparity, does this really add up to changes in life expectancy differences? Do we really close this gap, or do we just see perhaps people live a little bit longer at all levels, and the top keeps moving up even faster? I mean, I think that's really a very important question to ask. And here's women, and I think this is even more incredible, because you actually have potential loss here of life extension. There's no life extension. In fact, there's decreased. Up here, there's quite excellent life extensions. You can see all the way up to 92. But if you compare those two, actually men are the biggest winners in terms of life expectancy gain, because they pulled up to within 2 years in the top quintile of life expectancy with women. Whereas on the bottom, you see women are actually dropping. Men have stayed sort of the same at this bottom quintile. Women have actually dropped in quintile 1. Now, this is a study that was published in JAMA and on the association between income and life expectancy in the United States. And I think it's very interesting, because this is predicting life expectancy in low-income groups, low-income populations across the country and urban populations. And they used a geospatial unit called the commuting zones. So they said people don't just sit in one spot, they move within a certain areas in general, and we've sort of tried to calculate those and make estimates. And there's two things that stand out, and this is the reason I'm showing it to you. But the first thing that stands out is that, of course, as you would expect, if you do exercise, you're going to live longer. These are correlations. On the right-hand side is a positive correlation, living longer. So as you can see, the exercise rate here obviously brings up, the likelihood that you'll live longer. But all of the other positive signs are somewhat contradictory, in the sense that, as opposed to thinking that immigrants come into an area, then there's going to be more health problems and more healthcare need. In fact, having higher percentages of immigrants in the population actually brings up life expectancy. All right. Secondly, median home value. Third, local government expenditures and population density, all on the positive side, seem to float all the boats. And that is, again, somewhat contrary, because we always think Gini factor is terrible, the inequality factor is terrible. But in high-income cities, such as Los Angeles, New York, San Francisco, poor people live longer. They live longer in those cities than they do, for example, in rural areas that are poor or urban areas that are poor in the Middle West and the South. The South is, always stands out, as on all indicators, and I'll show you some other information about it later. So we know that these biological pathways to chronic disease are obviously linked to inequality and then to stress. The stress and unhealthful behaviors model, which a coping response. That's James Jackson's work that you heard about a little earlier, and I'll show that slide in just a minute. allostatic load. I mean, this is Michael Marmot. Michael, allostatic load, HPA access, metabolic dysregulation, being consequences of these kinds of stress exposures. And then, of course, more recent work has been done in several places, including at UCLA, cell signaling and pro-inflammatory activation. The stress actually creates what we would call, I guess, misfires in the activation system. Instead of protective things occurring, the opposite is occurring in some people, and you end up having inflammation, and you end up having, instead of protective responses from the body, you have consequences that in fact increase your risk. So going to those lifestyles of the poor, and specifically to the behaviors, this is from CDC, cigarette smoking, obesity, excessive alcohol use, sort of their big three that we see, and especially concentrated in the bottom 40% of the population. And this is the actual James Jackson stress elements in his index that he used in his studies that he said predicted the stress coping process for African Americans, leading to actually behaviors that were pernicious for them, because they were doing this to avoid depression. I mean, that's the original model, was to avoid depression. They are eating more, for example, and tend to become obese because of the fact that they are basically trying to cope with their circumstances. And so these were the items that they used in that, which are, I guess, more redundant in low-income communities: ever being threatened, harassed, life-threatening illness, accident, worse residence, losing a job, etc. Okay, just to give you a sense of that. And the stress index that he used was used in another study that was just published in Journal of Health and Aging, which I think the investigator was named Rodriguez, and he was actually from UCSF. And what he found was that high levels of reports of these symptoms were specific for African Americans for obesity, specific for Latinos for current smoking, and for whites ever smoked and obesity. And it really increments in a very linear way, which I actually have some data on that, but I don't want to spend some time on that because it's going to take too long to do that. So I've just been finishing and working on finishing up a long analysis I've been doing with health and retirement survey data, trying to understand what's going on in different regions of the country, and trying to compare ethnicities within regions and across regions, and what the role of income is under those circumstances, and trying to use a core health indicator to see what in fact happens under the conditions when you take something like obesity, and overweight status as an indicator. So what we did is we took the database of 23,433, and there were actually 11 waves of data. We used people in the study that had at least 7 waves of data per person in the study, and it included all ethnic groups, so not Asians though, because there weren't enough of them in the study to be able to do this. And we use Cox regressions here, proportional hazards model, so I'm going to be showing you slopes. And you're going to be seeing failure curves, which basically, in these types of curves, time is really just age. That's the way we look at it. And the failure rate, of course, is when you have an onset of some form of activity in daily living. So in other words, this is showing a sign at the end of life, the cumulative impact of what's going on with your body and how soon that's coming on. And we know that this is very different, for people in different statuses in our society. And what we found, interestingly, and when we asked these questions, I'm not going to show the analysis for this, I'm just going to give you the answer. The key research questions we asked is, are there regional differences in functional decline probabilities in activities of daily living? And the answer was absolutely yes, and it was highest in the South, and it was also high in the Midwest, lowest on the two coasts. Are probabilities of functional declines modified by differences in ethnicity, income, and health parameters, using BMI as the proxy for the health parameters? Absolutely, they were. They varied by uncontrolled by ethnicity, income, and health, this health parameter of BMI. However, is ethnicity associated with functional declines after controlling for demographics and BMI? No, it's not. Are regional differences in functional declines present after controlling for confounders? Absolutely. Those regional differences are still there. So we're seeing effects that are pretty widespread, in these areas that are affecting all groups in these areas one way or the other. Does economic inequality increase probabilities of functional declines after controlling for ethnicity and BMI? Absolutely, and that's what I'd like to show you, is how income is actually operating in that circumstance. And I'm going to skip a couple of the slides because of the lack of time to show them all. This is a first onset of an activity daily living deficit by selected BMI and income groups. And this is really fascinating here because what you've got here at this one, see if I can see it from over here. I'm not connected to anything. Can you hear me with the monitor I have on? Yeah, you can hear me now, okay. The line right here, which is, here's age, right? And here's the probability of having an onset of an activity in daily living, one or more. BMI, extremely obese, right? This is here, and these are among household incomes in the highest 75th percentile, all right? That's this line right here. So these are people who are in the top quartile of income, and they're extremely obese. Here is the line for people that are extremely obese but in the lowest group, lowest quartile, right? Down here, you have people that are extremely, they're normal health weight, but these people are in the highest income bracket. So here's their onset. They're normal weight, so they're presumptively somewhat healthy. And so what you see is the onsets are quite different. You can see the difference, for example, of the first onset occurring, here, when it occurred over here at 52 or 3. And when you look at the people who are also average healthy weight, but in the lower income group, they already have much higher risk despite the fact that they're healthy weight, which tells you that the total burden of disease and impact on the body and functioning is really greater in the group with the lower income, despite the fact that they've got a healthy weight. So, I think that one of the issues that we're dealing with here is that income matters all the time, and when you talk about disparities, and that when you try to rifle shot individual disparities, you may not end up with the end results that you think you're going to get in terms of survivorship and functioning in later life. Because there's more to it than that. The global burden is simply much higher when you're low income. Now, I want to turn a little bit now to the issue of place. What can place tell us about health destinies? How do geospatial units differ? And I think these are important questions that we really haven't answered satisfactorily. How do they differ in income health associations over the life course? We don't really know over the life course what those differences are very well. And how does the material infrastructure influence collective functioning and behaviors? And this is critical in an era where we're trying to push so hard for changing communities and spending a lot of money involving a lot of sectors who will have to come to believe that they're going to have positive benefits for the dollars that they've inserted into this process. We need to know a little bit more about what works best and how long does it take to work. What are the relevant variations in some group adaptive responses to material infrastructures? Because I think there's great variation in how people respond to these infrastructures. It's not all the same. You can see that very clearly by what happens with different groups, subgroups in the same area, and the difference in their outcomes. And then how do we sort through the complexity, of area context, area selection processes of who comes to live in there and who doesn't, or who moves away, composition, residential mobility, and it leaves the open question: is every geospatial setting or neighborhood unique? Is each one a case study? And the only thing we can really generalize from is by sorting them into economic groups, so we can see the concentrated poverty people do worse and the people in the middle do better. So I think that this is a serious question when you start talking about trying to go out, as we have done, with Communities in Action, Pathways to Health Equity, that was put out last month by the National Academies of Medicine. Now, the intent here was clearly to drive right at this issue of producing a situation where we can begin to address these issues comprehensively, lifting all the boats, trying to deal with the entire life risk process of different kinds of things being prevented or at least diminished in the likelihood that they'll continue on to fatal endpoints. The National Academies of Sciences, Engineering, and Medicine convened an ad hoc expert committee to consider solutions that could be identified, developed, and implemented at the local or community level to advance health equity. In the resulting report, the committee identifies the major elements of effective or promising solutions and their key levers, policy, stakeholders, and other elements needed to be successful. This is a 500-page tome. It's really big. It does a great job of speaking to some of the critical principles and issues. For example, it points out successful cases, which happened to be primarily all in California and Massachusetts. As a reviewer, I criticized that because I said that's going to be a pushback if I put them all there. But that's the way it turned out. The other issue I think they do a very good job of is talking to the issue of the necessity for having anchor institutions and communities or adjacent to these communities that can continue to persevere through thick and thin to carry these types of large organizational efforts forward. It's not just enough to have nonprofits in the community buy in for a while and to have a few professors running around trying to stimulate all of this with a grant from NIH. You really have to have stability over time, as we heard in the very last presentation that dealt with that, talking about, and that wasn't the last, the second to last, with Columbus, Ohio. I think that was an excellent example. And of course, that leads to my criticism of the report because I was a reviewer and I felt one of the big problems with this and one of the reasons I believe it's in jeopardy of receiving some lukewarm reviews is because, when people read this who are not those of us on the side of wanting to really foster this kind of approach and believing in it, the true believers in public health, you've got a problem of scope. It's not a cookbook. You don't know exactly what elements have to go in it to make it work. You really can't specify in advance how long it will take to get an effect, and what effect can you get, and how much will it cost to get a given effect in a given amount of time. And I think these are the kinds of issues that we have to start actually beginning to think about seriously if we want to gain continuing support to bring these things forward. Now, of course, it would be very helpful, such as in the example that we just got of in Ohio, if we could get some outcome data from those studies, hard outcome data that really shows us, what's going on. And we have some outcome data from some of the things that have been done, but it's just not, I don't think there's a big enough field out there of research that's been done in this area that can provide compelling evidence that under certain given circumstances, not cookbook, but predictable, processes that can go forward based on certain known principles, will give you a result. And where will it give you the result? What kind of behavior can be changed with what kind of interventions? Right now, I know we're in the business of doing very, very selected interventions that we get funded. I'm talking about us researchers that are in the room from NIH funding or CDC funding. And we tend to go towards, those narrow, windows that we get to be able to hit one thing. And the more narrow, the more likely you are to get funded, right? I mean, that's the way it works at the NIH. You have to be able to describe exactly what you're going to do, and then you're going to bring your armamentarium of research to it, with the best quality of implementation and fidelity you can. Obviously, that's not the way things are really going to work in a broad community spectrum where you're doing all of these things that have some more proximate and some less proximate relationship to really changing health. So is there some greater unity? Are there interaction of these components that come together that produce a greater effect? All these issues are really not known. So I think that these are the tough ones if we really want to continue with this approach, because I think right now when you go with this blanket approach to certain communities, they're going to say, are you kidding? I mean, what are we going to get for this? This is an enormous undertaking. So I think we really have to have in our vest pocket a really clear demonstration that we have accountability mechanisms, we can show cost effectiveness potentially for this, we can plan to look at outcomes over time, and we can specify the outcomes that we intend to look at. So I think that kind of approach was not as developed in this volume as I would have liked to have seen it, but it is an excellent piece of work and extremely comprehensive. So I really think that people interested in the community-based action should look at this. Now, bottoms-up strategies, community participation is obviously needed to address core determinants of health and well-being, including social determinants directly affected by stress, health, and functioning. Health and Human Services organizations have progressed in this in trying to move towards health promotion, disease prevention that is based on community-based models. And obviously, the more you are organic and right in the community, the more likely it is to take. But we all know that that's a hard thing to accomplish, and it takes a lot of time. And my dilemma with it has always been with junior investigators that they're the most vulnerable and they're the most anxious to do it. And they really want to get out there, and they're frustrated that they're not making those changes. But at the same time, they're also the ones who I fear are the most likely to have a problem with their career advancement, because these kinds of things don't produce a whole bunch of publications at the front end. This is a long-term commitment. And then, you may or may not get results, and you know how publishers of journals like results. They want to see, editors like results. They want to see things that have positive outcomes, not just negative outcomes. If you can have negative outcomes, at least be able to explain mechanisms that were involved in producing that outcome with very clear specificity. So the challenge of life course health equities and the transformation of cultural health really boils down to how much can we improve health of older adults without a corresponding improvement in income as population stress responds to growing and sustained income gap. I mean, do we know the answer to that? Is this something that we can really begin to get our arms around? Are there economists that can actually sit down and look at this issue and say, yes, for a given level of expenditure, we're going to get a given level of result, at least in some broad terms with reasonable error terms. Identify critical targets and indicators for major improvements and targeted life course income supports in the next 20 years. I think it's going to be very difficult to get direct income to low-income families, but I think we can argue for policies that are strategically placed in the life course to really improve health and improve development and sustain improvements, starting with early life and then, of course, the developmental sequences through educational processes and in midlife as well. So, and of course, later life. I mean, I'm not going to leave that out, being I'm an aging. I think that that's critically important as well. But without that, without really inserting some support at these places in communities that are highly vulnerable, concentrated poverty and above concentrated poverty, let's say it's still within the reach of the poverty level of 150% of poverty. These communities need that kind of injection of resources at very specific places, but those need to really be modeled and determine what would be the most, because resources are going to be scarce going forward, right? They're going to be scarce. I mean, we're talking about a situation in 25 years from now where we're going to have 3 people who are working and paying taxes into the system for every person that's a taker. Right now, it's 5 to 1. So we're reducing the number of people that are actually producing income to go into the tax base. And that population that's replacing the current population, unfortunately, may not be as well educated and as that high an income earner group as what we have right now, because it will be about 40 to 50% minority for those under 40. Of course, many things can happen in our society, including the production capabilities can go up. We can have possibly much higher productivity due to automation or anything, but then you'll have the problem of distributing income. So no matter how you look at it, we've got to develop more organic approaches in our communities, and that culture of health issue of getting people to buy into the orientation and understanding that their contribution has a discernible, explicable role with a payoff if they contribute to this process of changing our communities towards health. That prevention switch is something that, of course, to me was the most important thing under ACA that came forward, and it's the most likely thing to be on the chopping block as we go forward right now, from my perspective, if I had a crystal ball. So I think I just wanted to point out this crucible of professional responsibility because, I sit in a lot of reviews and I'm a counselor on some big grants that are center grants, and it's always the question of, you're doing really good work, you've got very specific hypotheses that you have to report to the NIH on, they involve community-based approaches, you're doing that. However, the community wants something from you, and you know what they want from you? They want really good data that they can use specifically with city council people and with supervisors, with state agency people, to get more money in order to be able to improve their communities and the health conditions in their communities. So that takes you a little bit afield from what you're doing for the NIH, yet you can do it. If you're an investigator, you've got data, you could spend the time, if you could get it, and actually go and sit in public meetings at the local level, the regional level, state level, and begin to lobby for these things. And this is an enormous tension, it seems to me, for people who are grant-based and have to survive on that, because you only got so much time, and you got a family, and you want to have a life. So the question becomes then, how much missionary is in you, how much commitment do you have, and how much can you really stake, especially if you're a junior person. So I think this is a real issue, and we know that science policy linkage is very shaky. It's a very weak one. We can develop all kinds of studies that seem to indicate something is good. It doesn't mean anybody will adopt it because they're not ideologically persuaded. So as a consequence of that, I think that we have to recognize it's going to be only through ultimately strategic approaches that we take toward advocacy. And I know this is about research, we're university people, but you can't avoid it. The NIH officially doesn't like that notion of advocacy, but let's face it. What are you doing that's a favor for these communities if you don't do something to help them in understanding your role as an effective advocate? So you've got the culture of health issue becomes really one of using data effectively, especially data that's proximate to the issues being faced by these communities, and data that's responsive to supervisors, county, city council people, to people or congressional people from a district, because if they see data about their area that indicates that there's things have not been done that should have been done, or indicates that there's a glowing problem that could be redressed if resources were brought to it, that's the way you're going to get that done. So it seems to me the most effective way, unfortunately, is the political way. And get that data and use it, and if it's not mandated under your project, I'm sure you can find a way to analyze it and get it for them. It just takes a little extra work. Coalition building, public and private sectors and health and human sectors. You've heard a lot about that already, so I won't redo that. But at the same time, I think it's important to understand that right now there's enormously important activity taking place that is very much in line with the issue of redressing the lack of access to care and the quality of care. In Los Angeles right now, which has a massive system, it has 1 million patients a year in the health services system, they've got had separate mental health, separate public health, and health services. They tried putting a uniform medical record system in and tried to do, placing psychiatrists in medical offices and this type of thing and hoping that this would make a difference. It didn't work, right? It didn't work. The cultures are too strong. The bureaucratic entropy is too great in these places. So what they finally ended up doing is crunching them together. They're still in the process of grinding this out, and they're going to just simply force them to integrate their services, physically, bureaucratically, and so that ultimately there'll be some accountability and there'll be transparency to what they're doing without a lot of pretend integration that doesn't really take place, because you still have to send people someplace else and they don't make the referral and they don't show up and they're not followed up. So ultimately, I call this kind of advocacy connecting the dots advocacy, right? Making sure that whatever type of interventions we're talking about in communities especially, that when money comes down from the federal government to states and block grants or whatever, or to counties and cities, et cetera, is it really going to be used for the purposes that it was intended? You've got this enormous complexity and discordance between, quite often, as we're going to see right now, I think, between the federal government and the state of Massachusetts, state of California. There'll be block granting, there'll be differences of opinion on how the money should be or could be used. There'll be fights about how much money, of course, and that's needless to say. But how do we know that that money is going to make it all the way down to the communities in which we're working, in which we're trying to do research and improve quality of care and quality of prevention and healthy lifestyles, without making certain that the original intent of those dollars is actually going to be maximized, at the local level? That requires a great deal of scrutiny, and it's really pertinent to our research because, communities can't do anything without money, and that's the bottom line. And I think you have a lot of communities right now that really feel like they're under the gun because they're operating so on the edge. So you're going out there and you're wanting to do research in these communities, and you're saying, well, you're going to bring some kinds of results, and obviously, it's going to be harder and harder to get that cooperation if there isn't some linkage to a process that's going to assist them in being viable. So I'm going to terminate this presentation by quoting one of the authors of the Affordable Care Act. This is historical. Every system is perfectly designed to achieve exactly the results it gets. So whatever system we have that's coming forward from Washington over the next 6 months to a year, that's going to be called, the new Trump healthcare, will be perfectly designed to get exactly the results it gets. And of course, that's where accountability, I think, has to be assessed. Thank you.
Thank you. Thank you, Dr. Vega. Very helpful perspectives about making a difference. So we're going to turn now to a panel where we have 3 distinguished speakers who are going to be giving us some perspective on making a difference with respect to the issue we've been addressing today. The panel is going to be moderated by my colleague Tom Byrne, who's an assistant professor at the School of Social Work, where he is making a difference in his work on homelessness, including people who are homeless who are also veterans. So Tom was the recipient of the Frank R. Broyle Memorial Prize for the best paper in social service review. Very impressive. And he's been doing work here in Massachusetts, funded by Blue Cross Blue Shield, and also importantly by the BU Initiative on Cities. So I turn it over to Tom. Thank you.
So I want to start just by saying thanks to Sally and to Gail and to Sandro for the opportunity to play a small role in this really wonderful symposium. And I think what I've appreciated about the conversation we've had so far today is that a number of the speakers have issued what I think are either explicitly or implicitly challenges to action. And we started with Dr. Morabia telling us that history is what we do today, and we've heard from Dr. Keller as well, challenging us to make sure that we have the correct stakeholders in the room. And so I think I'm hopeful that the panelists who are going to be speaking to you as part of this next panel will pick up on that thread and really talk to us in more detail about actions that they're taking in their work and that we can all take to move the needle on addressing health inequity. And so with that, I want to introduce our first speaker on the panel, Tanya Jones, who is the president of AIA Global and also a fellow at the FXB Center at the Harvard T.H. Chan School of Public Health. As president of AIA Global, which is a philanthropic advisory practice, Tanya offers strategic guidance to donor institutions and nonprofit organizations to enable them to reach their philanthropic goals. She's also a fellow at the FXB Center at the Harvard T.H. Chan School of Public Health, and for more than 15 years she's worked to improve the health of women and children in rural communities of sub-Saharan Africa as an implementer, fundraiser, and funder. She's also held positions at a number of other organizations, including the Barr Foundation. And Tanya holds a master's degree in public policy from Princeton University, as well as a master's in sociology from University of California, Berkeley, where she's also currently a doctoral candidate in sociology. And so I'd like to invite Tanya to the stage.
Good afternoon. Thank you. It's a true pleasure to be here, and I'd love to thank Dean Glia and Professor Bachman for inviting me to present to you today. I have a different perspective here in my training as a sociologist and a policy specialist, and I'm going to talk about my work in global health, which tries to address the disparities we've discussed today of structural barriers to health access, as well as how we translate research into policy that actually leads to improved lives for people in other parts of the world. So it may be a bit of a difference that we're talking about sub-Saharan Africa here, but I think some of the themes resonate quite a bit, especially as it relates to community-based initiatives, as it relates to ensuring that our participants and our subjects of our research actually benefit from our work, and that policies are enacted that will inform governments and increase opportunities for residents. In another role that I have, I've been in the philanthropic sector, and I've worked in foundations and also advised family foundations on how to steward their funds effectively to advance health around the world. So thank you for having me here. So we talked a little bit already about child mortality rates and the differences both within the United States and also internationally. And this here is a slide of the United States in blue, where we're at 7 per 1,000 live births, and comparison to other OECD countries, Sweden being the far left with 3. And we ask ourselves, and many of you have done research in this room, about what are the differences that these industrialized nations who have spent less on health care are getting much better outcomes in the US. And the next slide opens our scope a bit more, and this is courtesy of Dr. Glia, who shared this with me a year and a half ago, just zooming out now and looking on the far right, and we're adding Ethiopia to the equation and showing then, okay, the under 5 mortality rate of 70 per 1,000 live births compared to what we're experiencing here in the United States. So we're not just talking about inequality within a country, but now we have to look at it globally and understand what the issues about wealth distribution globally affect the outcomes for people in countries in different parts of the world. So Sally has insisted that the conversation turns now to not just what these problems are, which have been articulated so expertly, but just what can we do about it and what levers we can push as public health people, as social workers, as citizens, as philanthropists, as students. What are the things we can do to improve the lives of the people we care about in our communities and communities far from us? So on a day like today, in the last few weeks that we've been through, one of the first things I have to say is political engagement. And we need to fight for rights, our own rights, and for the rights of the people that we live with and share a nation with, and for citizens all across the globe. And if we forget that, and we are working in isolation and simply analyzing data, we have lost our purpose. And I want to talk about collective action, and I want to talk to the students in the room, many of whom are in the midst of graduate training and will soon be embarking on careers in public health, in sociology, in public policy, and social work, and think, how is it that I can engage the world with my knowledge and my skills, and in what sectors might I be most effective? And I think that the lens with which you come to your work and the training that you have in social justice and in epidemiology and in analysis will lend itself to a variety of sectors. And I have just listed a few here, and this is in no hierarchical order, but the advancement of health depends on all of these sectors and having quality, committed, engaged, and expert leaders working on all of these lenses. And I have had the privilege of, in the last 20 years, of working in several sectors, and one of those is philanthropy, which I'll talk about. The work that I describe in these slides emanate both from my work as an NGO worker in Ghana and also as in my academic research on sociology and policy in Ghana too. So there's a myriad of ways in which these skills and these commitments can really further the lives of people around the world. And I feel that the students in the room should know that there are probably very few errors you can make in the choices that you do pursue, so long as you are not in the private sector. My bias there. So I've spent my time on community-based healthcare, and it's a very important issue in rural Africa, where I've spent a lot of time. And basically, if we go back to the principles of the social determinants of health, the questions are income inequality, just on a national scale, but also as rural residents in remote areas of Ghana, this is a picture from Malawi, in fact, where there is limited access geographic to fixed facilities for receiving public health services, and there is few doctors who have the skills to provide curative care, and solutions have to be developed that enable residents to protect the lives of their children and to ensure the life of the mother who's delivering in very difficult conditions. And so here's Ghana there in the red, on the west coast of Africa, bordering Burkina Faso. A population of 24 million, a multi-party democracy with a fairly high under 5 mortality rate of 62 per 1,000. And the question that the Ghanaian health sector has asked itself is, how can we more equitably distribute healthcare services to our population so that we can get better outcomes? And what will be a very great, I guess, surprise to many of you in this room is that the decisions they made and the policies they enacted are derived from experimental evidence in a trial that was taking place in northern Ghana, well executed by Ghanaian and American demographers, that have shown that reorienting a nurse to a very rural residential location so that her patients or his patients do not have to travel to seek care, similar to our case in Texas, bringing the care to their doorstep and providing the services and the community engagement that's necessary to maintain this dyad between the community and the public health sector increases the child survival by 38% and reduces total fertility by 1 birth. So this is also an important point, which is this research cannot be done without resources, and it's funded by the USAID, the United States Agency for International Development, which was supporting an international NGO population council, which then supported the Ghana Health Service and the ministry to to administer the research. So there again, politics matter because we need foreign aid in order to do research. We need foreign aid in order to have NGOs operate, and we need foreign aid in order to support health sectors in governments across the nation, across the globe. So I'll leave this to the demographers and the epidemiologists to analyze at a later point, but I want to just simply say that the factorial trial, which shows the cell 3, where the Ghanaian health sector utilized nurses who are trained professionals and civil servants, a mobilized community harnessing the power of chieftaincy and community engagement and community volunteerism, in addition to rural household service delivery, brought about this change. So this is where the demographers took it, and the public service bureaucracy had to translate this into a real life situation, which to the rural residents of Ghana looks like a nurse on a motorbike with provisions in her pack and training in her mind. And with that skill and that ability, she can serve her community, or not necessarily the community that she comes from, but her clients, and provide information, preventative health talks, immunizations, family planning services that change the quality of outcomes for children, mothers, and general community members across the board. So I'm going to switch because I'm trying to show you how research informs policy, and I'm currently writing a book on this policy that is now 15 years old and has moved from that experimental research site into a national program that's in 110 of the 110 districts in Ghana, and is funded by both international agencies, the World Bank, the government of Ghana, and private philanthropists. But it is an extreme effort that requires advocacy, resources, expertise, and very committed health sector workers. So this also brings me to the importance of philanthropy, which is something that can move systems. And we have seen in the last 15 years the importance, particularly in global health, of foundations with the excessive wealth that are in the hands of very few. And there is a lot that philanthropists can do to advance the work that we all care about, and that practitioners, such as many of them in the room, who can become stewards of philanthropic funds and empower trustees and donors to understand what it is that their risk capital can be applied to bring powerful innovations and interventions into being. So this community-based health service delivery program is well known, thanks to all of the journals that published it and all of the advocacy that's been done around the world. But what the Ebola crisis 2 years ago highlighted, hopefully, to the global health community and to the public in general, is that the importance of community-based health systems, the strength of them, has an importance not just for the residents of the country, which we should all care about, but also for our global health security. And so I think that we all recognize the importance of these courageous medical professionals who show great sacrifice, skill, and commitment to work in very difficult conditions to reverse the Ebola epidemic in Liberia and Guinea and Sierra Leone. But I will also say that it took the commitment and the shoe leather and the community cohesion of both community health workers and community members to actually reverse the transmission of Ebola because of their ability and their willingness to change the behavioral practices of burial customs and information sharing that enabled the epidemic to cease. So this organization, which is based here in Boston, which many of you may know, Last Mile Health, it's quite an innovative nonprofit that is working in Liberia and has been recipient most recently of a TED Prize, works to train community health workers and have their skills and information, preventative health talks to the members of their community and reach them at the very last mile. And so we go from motorcycles in Ghana at the last mile to motorcycles in Liberia. And these countries work together, and the information and the expertise that the Ghanaian health sector workers have developed through their own community health worker program is being currently transferred from south to south, from Ghana to Liberia, so that that children and mothers and all of the Liberians can be protected from health crises that have clearly decimated the social sector. So clearly I'm passionate about these issues. And I'll just say that there are many ways in which philanthropy operates, and there are many ways in which it can be very effective and sometimes also not so effective. But we are also all philanthropists, and we have that ability, and we do not need to wait simply for the Buffetts and the Gateses of the world, though they certainly have their role to play. But just as we saw this last weekend with the ACLU, our dollars and our commitments and our advocacy moves issues forward. And so as we think about philanthropy and we think about the high net worth individuals in this country who have a great privilege and a great responsibility to move our health and our well-being forward, we too have a role to play. And whether it's in online donations or whether it's advocacy in the political sphere, there is no shortage of ways in which to engage this problem. So I'll just leave you with not my child, but a goddaughter who's ready to be active and ready to secure the rights of all human beings around the world. Thank you.
Great, thank you very much, Tanya. I'd like to introduce our next speaker, Harold Phillips. Harold is the director of the Office of HIV/AIDS Training and Capacity Development within the Health Resources and Services Administration, which is, as you all know, within the U.S. Department of Health and Human Services. In his capacity as director of that office, Harold oversees a team of nearly 40 staff, which administers the Ryan White program's AIDS education and training centers, special projects of national significance, and the President's Emergency Plan for AIDS Relief. Harold has worked for more than 20 years in the field of HIV/AIDS, and his work in that field includes past positions as the Deputy Director of the Ryan White Part B AIDS and AIDS Drug Assistance Program and the Director of Technical Assistance and Training at the National Minority AIDS Council. And I know from our conversation, some of the conversation earlier today has been about focused on breaking down silos, and I know from our conversation last night at dinner that Harold is a person that is actively working to try and break down those silos and help us address health inequity. So Harold.
Thank you. I'd also like to thank the School of Social Work and the School of Public Health for inviting me to be here today. And I'd also like to thank all of the staff that's been involved in the logistics for this meeting too. You have made this federal official and employee feel very valued and feel that my work matters, so thank you for that. I'm going to talk a little bit today about the Health Resource Services Administration, which is one of the agencies in the U.S. Department of Health and Human Services. Our other sister agencies, such as CDC and NIH, very often people know them, but they go, who is HRSA? What do you do? So I'm going to talk a little bit about that. I'm going to talk about also the work that we have done within the Ryan White program that I think really, some of the topics this morning really resonated with me and also helped to reaffirm the direction that our program has been taking in the last couple of years, especially given 25 years of the HIV epidemic in our program. I'm also going to talk a little bit about the data that we saw and use it as an example of what is actually possible when you really think about addressing health inequities, and then show you where we are today. So in terms of HRSA, you know, our programs that are out in the community, our mission is to serve the most vulnerable Americans and improve their access to health care. One in 3 people living at or below the poverty level relies on a HRSA-supported health center for primary medical care, either in our federally qualified health centers or the community health centers, which has a very strong and long history here in Massachusetts as a result of some really innovative thinkers and pioneers, I think, in the field of trying to provide access to care. 9.7 million people live in a health profession shortage area, and they receive care through the National Health Service Corps, which is another HRSA program. More than half of pregnant women in this country and more than a third of infants and children benefit from our maternal and child health programs. Over 700,000 rural Americans receive health services thanks to the rural community-based grants in the Office of Rural Health Policy. And 10 million people living in health professional shortage areas receive primary medical care, dental, or mental health care from a National Health Service Corps clinician. And the program that I'm going to talk mostly about today is the Ryan White program. And within that program, 1 in 2 people diagnosed with HIV in our country receive care through that program in our country. So that's a little bit of who we are. I know folks don't often hear about HRSA and what they do. But when it comes to the work of the Ryan White program and what we have done, our program sits within the HIV/AIDS Bureau. HRSA as an agency is an over $10 billion agency. 2.3 of that is housed within the Ryan White program, which has various levels of funding. We fund clinics themselves, but we also fund city, county health departments, as well as state health departments to provide systems of care and improve those systems of care. I have said that working in HIV in my career, it's enabled me to see the best and the worst that our country has to offer. It's also enabled me to see the opportunities and also the challenges. And I would add, that even domestically, when I think about what we've been able to accomplish with American dollars, American ingenuity, we really have been able to make a difference. And working in the field of HIV has allowed me to be able to see that. The Ryan White program is a patient-centered medical care model. It is a program that allows us to fund gaps in services within communities based on their particular need, which means that we have to ask the community, what do you need? It also is a program that recognizes the fractured healthcare system within our country. And the program was always designed since 1990 to fill gaps in access to care. And so it has called for us to have a partnership with the community of both providers and those who need care to figure out how to adequately target the resources from our program to make that difference. It's always had, as part of its legislation, payer of last resort. I think I give credit and shout out to Senator Kennedy, the late Senator Kennedy, who always believed that there would be some other form of payment for health care in this country. And when he and the other framers of the Ryan White program put this together, they put that clause of payer of last resort, meaning that if there was another way to cover the health care needs of individuals living with HIV, access that program first and the Ryan White program last. So we've always been a gap filler, wraparound program that has been patient-centered in its approach. One other thing that I wanted to say about our program, Part F services, this allows us to do things such as the special projects of national significance, where we look at innovative approaches to service delivery and service models, and also our AIDS education and training centers as well. So I'll talk about those and the importance that they have played in our framing of this as well. A little bit of the data of who we serve. As you can see, the majority of our clients are Black, African American, almost a third are white, and 24% are Hispanic and Latino, multi-races, and then we have Asians, American Indians, and Native Hawaiian and Pacific Islanders. So we're almost following the OMB requirements and how we collect this data. When we looked at the data I'll show you the 2015 data first, in looking at transmission risk categories. The majority of our patients, our clients, male-to-male sexual contact, also very decent-sized population, heterosexual contact. Most of those are women as well. And so this gives you a little sense of who we serve within our program. Within the program, there are about 500,000 clients. What the Ryan White program has done successfully since about 2010 is collect client-level data on almost 500,000 clients that we serve through our program. And so, as I said earlier, those individuals with diagnosed HIV, 1 out of every 2 of them receive care through the Ryan White program. Our data set has enabled us to really dig a little bit deeper and look at not only who we serve, but also it gave us a window into the health disparities issues as well. In looking at our clients by age group, this, I think, matches sort of what we see about HIV infection in this country. Those that we are served primarily are in those middle ages, but we're also finding that our clients are growing old, we hope gracefully, living with HIV. So that's part of the success of what treatment looks like in this country. But it also presents additional challenges for us, as some of the speakers have talked about this morning, about the impact on age in health outcomes as well. Our clients also by gender and transmission risk. What we began to see as through some of this is that the majority of our clients were male. Most of them were men who have sex with men, or either gay or bisexual men. But when we began to look at the data on viral suppression, which is the ultimate goal when we are treating those who are in care, we saw some things that were very different. So am I going backwards? We don't want to do that. We don't want to go backwards, no. There's enough of that. In looking at our client level data and the 500,000 client records, we began to use it in a lot of different ways, both for planning, both to try and address some of the gaps, and also looking at ways to improve service delivery and improve overall outcomes. The data sets really enabled us to look at closely some of the following initiatives that came out of it. One way that I think looking at this data and really thinking about it and using sort of your platform, and this is for the students, I think, picking up on some of what Tanya said earlier, using your platform from where you sit to really think about how can you build bridges, how can you create coalitions, how can you challenge the status quo. I had the opportunity to go and sit at one of those Washington policy and data meetings where they spent all day, and Dr. Wheeler talked about this earlier, the data where they showed that 1 in 2 African American gay men has a lifetime risk of 1 in 2 of becoming HIV positive. And it was a horrible meeting. I mean, the data was great, but it was a horrible meeting in that I left at the end of the day thinking, what am I supposed to do? And I was exasperated. And I went back, I met with our bureau administrator on one of those Friday afternoon conversations that I have with her sometimes. And I sat down and I said, don't send me to another meeting like that, please, God. I said, the data they presented, it was upsetting, it was challenging. I left with nothing to do. And she said, well, what would you do? And she said, let's take money off the table. Let's imagine we have all the resources we do, because we are the federal government, and what would you do? And I said, I really don't know. I don't feel like I have an answer, but I can't sit here in Rockville and believe that the answers aren't out there in the community. I have to know that there are people that are doing really excellent work that's making a difference. We just don't know about it sitting here in Rockville. And she said, well, maybe that is the answer. And it did turn out to be the answer. What we did was we began to create a funding opportunity announcement where I used to call them my black MSM detectives. They actually went out into the community, they met with providers, they met with clients, they heard about what was working. And the measure for us of what was working was, are you virally suppressed and are you being retained in care? And we learned so much. And our approach was really around gathering some of those best practices and then being able to provide technical assistance, but also building awareness within the communities and also their capacities. A lot of this was also happening at the time of the ACA, and we knew that we had a problem both with health literacy and health insurance literacy. And so really we began to stand up initiatives to really try and address those, because when we're talking to these populations about being connected to care, as you've heard from many of the speakers today, they don't have a connection to primary care. They don't have a connection to preventive care. Sometimes care happens in the emergency room setting. So to tell someone you have a life-threatening illness and now I need you to have a lifelong engagement with care and take your medication consistently and appropriately, it's like speaking Greek. So we really had to work on some of those issues through some of our programming efforts. The initiatives where we pulled together through the funding opportunity announcement, the Center for Engaging Black MSM Across the Care Continuum, we talked with many of the major stakeholders about what was making a difference. Some of the things that emerged for us that really impacted what we are doing moving forward. Focus groups talked about how the client priorities and the provider priorities are out of sync. Many of our young Black MSM, their focus is on going to school, getting an education, getting stable housing, and having relationships and feeling valued in their lives. And so really working with our providers to understand that for you, HIV may be the first issue and the presenting issue, but it's not necessarily the most important issues in the lives of young Black gay men. As you can see from this, we looked at our viral load suppression data back in 2010. 69.5 is nowhere near the 90-90-90 that the UNAIDS wants us to get to. By focusing and really having these dialogues with the community and really bringing together some of the coalitions, really also improving the way we train providers, we've now gotten it up to 83.4%. So we think it's not where we want it to go, but we know that it has to be about us thinking differently about some of those social determinants of health. Some of the things that we're thinking about moving forward are, what is the role of employment? What's the role of education? And so for the first time as an HIV program, we're building coalitions with the Department of Labor, the Department of Education, and trying to look at, can we do blended funding streams that really address some of these issues and really can get to the population in very different ways. I'll also just quickly flip through some of this because I'm probably running, I'm good, all right. So this is also another way to look at what we have also been finding. So the green line is men, blue is women, and the orange line is transgender clients. We're also finding a disparity among that population as well. And so being able to drill down with the data has really given us the opportunity to see who we're serving, what kind of job are we doing, and then have conversations about what should we be doing better? What are the priorities for you within your community? And then using what I sometimes call the federal levers to pull the right people in and create programs and blend funding streams that really do make a difference and speak to these issues. Again, this is another way to look at it by age. We know our young people and men are extremely difficult to keep in care. I'm still trying to crack that and figure out what needs to be done differently. But again, as you can see, our young people are still lagging behind. But my administrator, who also sees patients in Baltimore on Friday morning, she sometimes goes, I get so frustrated sometimes. I can get someone who's 18, 19, settled, on care, virally suppressed, and then they'll break up with their boyfriend, and it's the end of the world. And I'm trying to tell them, you're 20. There's a lifetime of love behind this. Please continue to take your medication. And so it's learning, but as a clinician, she knows that she has to have that conversation, she has to have that dialogue, and she has to keep pushing and trying in order to keep them connected to care, but let them know that she does care about their issues, but we still need you to take your medication. The other thing that we are finding with looking at our data is the connection between housing stability and the ability for individuals to become virally suppressed. This data is one of the biggest indicators of sort of success or treatment failure is housing status. And we collect that information as part of our data collection within the Ryan White program. And what it has caused us to do is really think about housing as a structural intervention to healthcare, and really working with our partners at HUD around this issue, and also other, I think, housing providers, both at the local and national level, to have those conversations. Some other things that we're doing on the federal level to address disparities include the Secretary's Minority AIDS Initiative funds, which allows us as federal agencies to propose innovative strategies to address some of the racial and ethnic disparities to the Secretary's office. The Special Projects of National Significance, which BU is a grantee, and which I'm very happy and excited about. Some of the demonstration projects that we have done, what we do is we fund them for a number of years. They're innovative service delivery models. We disseminate them and push for replication across the country with those. Also creating learning collaboratives. One of the things I didn't show in my data is that we also show great disparities in the South around HIV, infection, and also treatment folks with HIV in the South as well. So we've created learning collaboratives of grantees and providers in the South to really do a similar thing to our CBAC initiative, look at some of the outcomes and some of the issues. And then also we have created some really innovative partnerships with other federal agencies to present this data, because one of the first steps is making them aware of these issues and being able to bring them to the table and figure out where we have common purpose and can work together. So that's been a really effective tool as well. And then also making sure that the data is available on the local level within communities again. So really the work in closing is to assess the trends, focus more on some of our affected communities, and really work with them in collaboration to develop strategies and activities that are culturally appropriate, and really engage with them to help inform us in our decision making and assist with the implementation. And also engaging and training our care providers on these issues too. Having them see this data and understand it has been a really important key to getting them to think differently and getting them to treat differently. Thank you.
Thank you very much, Harold. As someone who does a lot of work around housing and is well aware of the negative impacts of housing instability, I especially appreciate the call for the need for more attention to housing. So I just want to now introduce our final panelist, Dr. Pamela Riley, who is the Assistant Vice President for Delivery System Reform at the Commonwealth Fund. Dr. Riley's area of focus is on transforming healthcare delivery systems for vulnerable populations, including low-income groups, racial and ethnic minorities, and uninsured populations. Dr. Riley was previously a program officer at the New York State Health Foundation, where she focused on developing and managing grant-making programs in the areas of integrating mental health and substance abuse services, addressing the needs of returning veterans and their families, and diabetes prevention and management. And she's previously held positions at the Stanford School of Medicine, as well as other institutions as well. So please join me in welcoming Dr. Riley.
Good afternoon, everyone. Thanks for having me. It's great to be here. Just a little bit about me. I used to be a real doctor as well. I worked as a pediatrician at a FQHC out in California. Then I decided to get my public health degree, and I'm glad I did, so that I can work on a lot of the same issues that I was facing on the ground a few years back. So I am going to tell you a little bit about some of the work that I'm doing now at the Commonwealth Fund, and how does that get us where we need to go in terms of actually improving equity for vulnerable populations. So the Commonwealth Fund, we're a private foundation. We're really focused on creating high-performance health systems, particularly for vulnerable populations, and we do that by primarily through funding research and convening relevant stakeholders, making sure that we understand what the needs of the populations are that we're trying to serve, what are the best models of care to help meet those needs, and then finally, what are some of the payment and policy structures that need to be in place in order to advance the most appropriate models and really expand access to care and good quality care, particularly for vulnerable populations. So I just want to talk a little bit about what are some of the current opportunities in presented by some of the more recent changes in the healthcare system to really work towards closing the gap between vulnerable populations, whether that be low-income, minority populations, and those that are more advantaged. And how do we really leverage those opportunities to get where we want to go? So there are a couple of pointing out the obvious things that I just want to cover. Number one, there was a huge opportunity with the Affordable Care Act, you've probably heard of it, with expanding coverage, because those coverage expansions primarily benefited low-income populations, and if implemented as designed, it would have implemented a lot of minority populations as well. I think there are benefits that have already been gained. It remains to be seen what's going to happen with that, but I think number one, it speaks to the importance of actually having coverage in place in order to get into the door of the healthcare system. You can't get better if you can't get in. But also in being able to, from the healthcare system perspective, you can't help people who can't get to you. So it really goes both ways in terms of ensuring that there is sufficient access and sufficient funding and financing for healthcare providers to provide care delivery to these populations. So all that to say that coverage is important to being able to improve care delivery, and it just means that there's that much more at stake if there are changes to the coverage expansions that are currently in place. The second point, which you've already heard about today, is that there are new models of paying for care, moving to paying for value instead of paying for just widgets, procedures, visits, that really encourage healthcare providers to focus on population health, and are holding providers accountable for improving care, reducing costs, improving efficiency, and actually thinking about the health of the entire population. So I think that adds some a little more impetus to focusing a little bit more broadly on issues around disparities and equity, and also thinking about opportunities. It also creates opportunities to incorporate a broader array of services that can have an impact on equity-related outcomes, things that are some of the non-medical services that we've heard a lot about today, the social determinants of health, just as an example. I do want to talk about the coverage point because I think it's just so fundamental. It is a very simple answer to how do you achieve equity, expand coverage. And I think we've seen that. There are still disparities that exist, but through the years of under the Affordable Care Act, we have seen that coverage has improved across the board. It has improved for all groups. There's still a lot of work to be done, as you can see, particularly for foreign-born Latinos. But coverage helps. Coverage helps to improve access. We know that, and it also helps to reduce disparities. That's not the entire story, but it's a big part of the story, and it, again, just speaks to why there's so much potentially at stake. This is a study that the Commonwealth Fund supported on looking at Medicaid expansion. Medicaid expansion helps improve access to care. This is a comparison of 2 states that expanded Medicaid and 1 state that did not. In the states that expanded, we see improved access to a personal physician, less skipping care because of cost-related problems, increased visits for appropriate care. So, we know that coverage reduces, in this case, the disparity between people who had Medicaid and people who don't. It actually addresses those disparities. So it's just something for us to think about and keep our fingers crossed that it doesn't go in the wrong direction. But it's just really fundamental to actually being able to capitalize on trying to make improvements in the actual care delivery. So I want to shift to the care delivery side and to the new payment models that you've heard a lot about today, really focusing on how do we move from paying for doing stuff to paying for getting better outcomes. And as I said, there's a lot of models in place that are really enabling us to take advantage of that, such as the Accountable Care Organization, which you've heard about as well. It's really a model that enables partnerships between the healthcare system and other relevant stakeholders, community-based organizations, public health, all kinds of stakeholders, payers, to really be accountable for the healthcare and health outcomes of a population. And so I use this to illustrate that there's a lot of opportunity here to use this model to actually address issues around health disparities. I think there are challenges to actually doing that, and challenges to realizing the full opportunity that's presented here. But there are a lot of accountable care organizations, particularly those focused on the Medicaid population and vulnerable populations, that are really attempting to use this model to leverage partnerships to really make a difference in terms of achieving equity for the populations that they serve. I just want to use one example, Hennepin Health, which is a Minneapolis-based ACO for a very highly vulnerable, highly complex Medicaid population. They have really explicitly designed their ACO model towards addressing behavioral health issues as well as addressing a lot of the social determinants, and they're showing a lot of promising outcomes in terms of improving care. They've seen improvements in the populations that are actually receiving recommended health care, given the model that they're using. They've also focused quite a bit on, as I said, the sort of the social determinants. They've focused quite a bit on how do they employ housing to realize some of the goals of what the ACO is trying to do in terms of improving appropriate healthcare utilization, decreasing inappropriate utilization, and they've seen some promise here. So it's just one example of an ACO model, or another example of an ACO model that is really explicitly trying to address issues around achieving equity for this group. So we have funded them to do a partial evaluation of what they're doing, and as part of that, they will be looking explicitly at racial and ethnic disparities as well to see if not only, I think part of the challenge is that there's a lot out there that is improving care for very vulnerable groups, but taking it the next step of actually achieving equity and closing that gap, that disparities gap, I think it's a next step, and it's a bit more of a challenge, I think, for a number of reasons, but they're actually focused on trying to do that. With the opportunities that ACOs afford, I think there's also some potential drawbacks. So we're also funding research to be aware of sort of the promise and the perils, potential perils, the pitfalls of ACOs for vulnerable populations. So we just funded a study through Dartmouth, the Dartmouth Institute, looking at ACOs serving vulnerable populations. Minority populations have a harder time meeting quality metrics, and that's something that we've known for a while, that health systems that serve a lot of minority populations have faced greater challenges meeting quality metrics. And that has a huge impact ultimately on disparities and outcomes. So it's just important to gather data on that as well. I just want to mention the patient-centered medical home. It's a concept that's been around for a long time, but it's really the building block of a lot of these ACO models, particularly those that are serving very vulnerable populations, because we know improved access to primary care and greater coordination, it makes things better. And we have data to show, research that shows that it actually does reduce disparities, racial and ethnic disparities in access to care. So I would just keep that on our radar too, that we do have a lot of tools and know a lot about what works to address disparities, but I think there are some areas where we could use more information in order to sort of make that happen. So one of the issues that I struggle with on my end is, if we know all this, we have all this opportunity here, what's missing? Like I've asked, a lot of people who research disparities or on the health system side, why is it if we have these, we're holding systems accountable for improving quality, containing costs, improving outcomes, why isn't reducing disparities one of those outcomes rather than just improving for everybody? Why isn't closing the gap an outcome? And I think, there are a number of things. I think there's certainly interest in it among, health systems. I don't think it's for lack of interest or or will, or at least among a certain sector that are serving this very vulnerable population. Could there be more expanded information on what is the sort of, I guess, value case? What is the contribution of disparities towards impeding your progress towards improving the outcomes that you want to achieve? But I think there's certainly a lot of, the interest and the will is largely there. How do we help to capitalize on that? Do we know enough about what works? I think we do. I mean, I think we know a lot about what works, certainly, obviously, improving quality, that helps. Coverage helps. We know a lot about what works. I think one particular area where we could know more is around addressing the social determinants of health and the role that plays in shrinking those equity gaps. I think there's definitely more room to know about what works in that space, how best to implement it, how best to engage community partners, what those partnerships should look like in order to be of maximum benefit to everybody. I think there's a lot more room to grow in that area. And then finally, data, which you've also heard a lot about today. You can't improve what you can't measure. And I think we have made a lot of moves towards getting better at data collection, particularly around race, ethnicity, language, but there's still a long ways to go. I had a conversation with someone at Ascension Health, which is a large Catholic health system. They are starting to prioritize, or how do we get to tying some of these payments or compensation or something to disparities outcome, not just to improvement, but to closing the gap. They are looking at doing just that, tying some of these disparities reduction measures to their executive level compensation, just as an example. And there's a lot of interest in doing that, but in the interim, they have Medicaid data, but they don't necessarily have all the complete race ethnicity data on their population that they would need, even though they're working on getting there. So I think there's, data is a big part of it, and having the data available is a huge hurdle that I know a lot of systems are working towards, but it's going to be a big missing piece. So those are just a few thoughts as to, what we could do, but we still have a ways to go. Thank you.
So I'm going to ask the panelists to come up. As we've been, the model we've been following, we have time for a few questions, and then we'll have a couple of closing remarks from Dean Steckity, and you all have earned a reception. So we'll get some more chance for conversation at the end. So, Tom.
Sure.
Questions?
Well, I certainly have at least a few. So perhaps I can start it off. I had a question for you, Dr. Vega, around, you focus very specifically on the relationship between income and health. And I think I would be curious to hear your thoughts on, the fact that is a relationship that could potentially go in both directions as well. Not just income being related with worse health outcomes, but actually that relationship reinforcing itself, where less desirable health outcomes can reinforce income disparities between groups.
Yeah, I mean, I think there's a couple of different issues there. I mean, I think one thing is that we're doing work that in some areas where we're seeing improvements in the levels that we're seeing in morbidity in specific disease categories, but it's not necessarily closing the gap. Mm-hmm. And that's my concern in the whole picture, that when you look at, for example, life expectancy, you may be able to start finally moving the ladder up a little bit here, people climbing to longer life expectancy at the bottom, but they're likely to go at the top even faster. Mm-hmm. That's what we're seeing, right? So catching that tail is not so easy to do. And I think that in the end, we don't really know if we gave, it'd be interesting, and I don't know why they don't do it. We could do natural experiments here, and look at populations in different kinds of situations and actually give, and they've done this, by the way, in certain retirement studies abroad, where they'll give a population a certain amount of money beyond the regular amount that the pension, and then they will randomize it and they will look at what happened to the group and how did they use the money. Was there good outcomes? Were there negative, not foreseen outcomes like maybe alcohol use or something because they got more money, is that kind of thing. And overall, those experiments have shown very positive results. They've actually shown that people that got more money were walking more, they were buying more medicine, they were buying more food. And hopefully the right kind of food. That would be an important thing too. But I just don't think that we've had much flexibility in thinking how we can use money in a direct form or an indirect form to improve health.
Yes. I guess we'll go here.
On that note, I wanted to ask if you knew about Dr. Ito's work out at the Policy Link in California, where he did an asset map of Oakland and mapped all of the disparities, and of course they all centered in one community.
Mm-hmm. Yeah.
Then he mapped every not-for-profit organization in that same area, their budgets, added up their budgets, and calculated that if you closed all those agencies, you could give every man, woman, and child in that area $177,000. So it was a very provocative presentation, and in terms of how we're using money, it's really making me think.
Yes. I couldn't agree more. And obviously you're fighting a lot of impedance if you try to get there, right? And a lot of hard decisions would have to be made. But that argument has been made more than once by people on both sides of the political spectrum. Mm-hmm. And so it may be that going forward we'll have to do something in that arena because we won't be able to afford to sustain so many agencies, et cetera. And it's hard to say, what they're accomplishing, per unit of service delivered. And without better data, it's hard to know one way or the other.
I just wanted to follow up on your question on just measurements and that could be used in incentives because I'm very much aligned. There are several Medicaid states that are doing pilots right now. Ohio is said in 2019 they're going to pay Medicaid managed care organizations more if high school graduation rates go up. And Seattle has a proposal for early childhood kindergarten readiness, as does Portland. But in those contexts, no one's been willing yet to say people should be paid differentially based on inequities by race or gender or any other specific class. And I just wondered if you'd comment on why you think that's happening and what we could do to fix it.
Yeah.
Well, I think the blocks are ideological, don't you think?
Well, I think it's a couple things. So there are a couple, as you mentioned, there are a couple states that are trying these really cool, innovative things, particularly in Medicaid. And there's a handful that are thinking about how do you, should we include risk adjustment for some of these factors in terms of the payment. But I think the problem is when people throw out the risk adjustment thing, it's like, oh no, we're holding this group to a lower standard. You don't have to improve care as much for these people over here. And I think that's where the stickiness comes in. But I think there's certainly an argument to be made for, okay, you could hold people to the same standard or figure out how to hold people accountable for improvement, if not achieving the exact same standard, going in the right direction, or just pay differently, pay more, rather than holding them accountable to a different quality standard. So I think there's ways to do it. We're actually just starting a study that's looking into, I believe, Massachusetts and Minnesota are thinking about doing this. How are they doing it? How are they able to make it work? And how do you make it work that continues to encourage improvements in quality rather than just sort of complacency and say, well, I don't have to worry about this population?
Good afternoon. My name is Nick Gentili. I'm a Northeastern University nursing student. My question's primarily for Dr. Riley. I'd ask you to comment on what you think the efficacy of universal health insurance would be as opposed to universal health care. I don't know if that's a little too off base. I certainly don't know all the intricacies of the subject, but my view has always been that universal health care is, health insurance is more of a middleman in the situation.
Well, I guess you're right. Yeah, I mean, I mean that's ultimately what we want, is for people to be able to get care, and insurance is the way that this country has decided to pay for it. I think, you know, given where we are, you know, universal coverage and care is kind of a non-starter, even though ideally, yeah, that's where we need to go. But yeah, I think it's ultimately you want to make sure that people are getting the care they need when they need it. I think coverage is the way that we have decided to proceed with getting there, and it's kind of a patchwork, to say the least. But yeah, I mean, that would be the way to go. That would be the ideal.
Right.
So. No. I mean, politically, no. Like, I mean, it's yeah. Sorry.
Right. I would add that under the Affordable Care Act, and these are some of the lesser-known provisions, there were also provisions that were designed to scale up the supply of health care. So there were pieces that involved healthcare training, opening new access points as well. So we did more than just coverage under that piece of legislation, but you know, much of the talk and the rhetoric is around sort of the coverage itself, but we still have to think about the issues of access and also making sure that we have a workforce that can meet the needs of vulnerable populations.
Yeah, I just want to say I think it's, and I'm sure that Eliseo would have a comment on this. The population that has least access, which is the immigrant population, Latino immigrant population, actually has the best outcomes in terms of longevity in these groups that have similar income, right? So it obviously isn't all about getting care and having access to care, because they're unlikely to have usual. I'm not saying you shouldn't have it, but they're unlikely to have a usual source of care. I mean, the majority go to some doctor rather they pay for when they need it, right? But I think it goes a lot to lifestyle, you know, related issues that creates resilience. And the need for less reliance on formal systems of care. And I think that's why, in the end, it's really an organic problem of rootedness in social networks and communities that are protective.
And you made a good point during your presentation about some of the provisions that talked about prevention and health promotion that were also in there that may be some of the first to be cut.
I am sorry, but we're going to, we need to stop this part of the panel. I want to thank everyone for your presentations. Thank you, Tom. I've asked, maybe if you guys want to just, if you don't mind staying here, Dean Steckety's going to, she's been taking notes all day. And she said she has one page. She's got it summarized to one page, so you can see why she's one of the most productive scholars among all social work scholars in the country, to be able to wrap all this together into a sensible conclusion for all of us. So thank you, Gail.
She thanks me prematurely. So one strategy for figuring out who should end incredible symposium like this with a lot of great minds working on health inequities is by asking the one person in the room who knows almost nothing about health or health inequities to give the summary. So that's me. And what I certainly want to do is thank all the speakers, because you were excellent. I know we've lost a few of you along the way to time and travel. Everybody came from a long distance. Even if you were local, you gave up a lot of your time. So it's been wonderful to listen to you. I learned a great deal, and that was fun. What I'm just going to do is try to pick out the pieces that stuck for me. I'm a social worker by training, but also a clinical psychologist. Grew up like that. That's my environment for my research. And so I get to come at it from a somewhat different angle. And what I would say is that it's impressive how many different disciplines came into the room. and spoke to us. And so that tells us how hard the problem is, because we can't just locate it in one area. It's got to be broad in our focus. And we also learned that they use a lot of different methodologies, which also seems to be a critical aspect of what we're trying to do here. And we're coming at it from so many different angles that the hard part is to understand what we do, get us in the same room. And now my reaction is what we need is another couple of days of listening to small groups of you hash it out and figure out how to move forward. So I'm just going to try to pick out a few things that I thought were interesting. One was, why study it? And I thought, the goal of justice, and I think it might have been Daryl who said that. I'm going to lose track of who said what at this point. It's been a few too many of you, and I'm getting up there in age. But the goal of justice did make sense to me, because justice is one of the longest standing historical phenomenon, if you think about it. This is way back in BC times where there were justice systems. Apparently, human beings care about justice. We now know that dogs care about justice. So what the heck? Let's try to, where can we go with that? Because if we care and we think it's just, but other parts of the country take some convincing, how would we get there from here? It is an age-old anchor for us. And then the other thing that was an interesting conversation was the inequities and inequalities piece. And I liked the analogy, if you give this step up, and you could even have a ladder in different levels, a lot of us do work on that level to do that. We talk about resilience, we talk about coping, but in fact, if we could tear down the fence, it would be way better for everybody. And the question in my mind is, are there actually countries in the world that have torn down the fence? And if they did it, how did they do it? They are human beings. So I do find myself wanting to know more about that, and I just don't know enough from the global arena, which I know is an important factor for us. So I find myself wanting to work less on resilience and coping and more on something that would drive it forward with as much power as we can figure out how to do. I found it interesting to think about, I think this was David Takeuchi who talked about othering. We naturally do the in-group and the out-group. We do it all the way through our childhoods and so forth. How do we get beyond that? Can we actually change our own bias? And it made me think that, implicit association test, we should probably all take that. We should all have our students take that. I'd like to know just how bad it is and what I'm dealing with here. And therefore, what I could do about it. So know thyself, I suppose, is that kind of commentary. The other part that's really interesting is the tale of two cities. And my reaction is, why didn't I know about Columbus and what it was doing? And the other is what it's clearly taking to pull that together. And that's like the people in this room. It's along with everybody who's got the money and can control the neighborhood and the circumstances that are going on there. So it's an extremely interesting experiment. I'm sure there are others out there that I know nothing about, because it isn't my field. But we also do know that money talks. A great deal of what happens in the world, it happens because somebody's got the money to make it happen. So the philanthropy piece of it, the research funding part of it, the bankers who are going to give out the loans, the people who are going to build the apartment buildings, and on and on and on. So if we can figure out how to appeal to the money, it seems to me that we are likely to get a lot more leverage here. And so that's also going to take advocacy, and I know people have spoken to that. It's certainly something that social work does a lot of, public health is doing a lot of, et cetera. And then lastly, to selling it. I find myself thinking hard about marketing and communications, having just watched an election that didn't quite go the way some of us would have liked it to go, and how we use the media to change bias. We are not very good at projecting the positive news in sound bites and or whatever it takes on a PR level to make it interesting and entertaining and to capture the newspaper's focus or the local reporter or whatever it is. And we get on there from time to time, but we're not well trained to talk like that, to talk to the public at large. So I find myself wanting us to get better training in just how to do that. So the many angles to work on. I thank the presenters. I had a great day. I do have a lot of notes if anybody wants them. Thank you.
Thank you, Gail. That was as perfect as I knew it would be. Thank you for that. So thank you all. Dean Galea, do you have any final words for us? So thanks, everyone. I couldn't be happier with the way this has gone. Thank you for your contributions, your discussion, and I will meet you in the back of the room.